Hi, very good morning. I'm Dr. Janak Patel, MD, General Physician. All my video lectures are mainly for educative purpose. This is one of the topic which is very frequently asked as a full question in your theory, as well as it will be very important in your oral exam also. And good number of time it will be helpful to you when you go for your private practice. So today we are going to discuss regarding the second part of optic nerve examination or second cranial nerve examination, that is optic nerve pathway, field of vision, and finding due to lesions at different levels. Field of vision can be measured by confrontation method, perimetry method, or computerized method. These are the two field. One in horizontal field, again it is not more than 180 degree. It is approximately around 130 degree, and even in a vertical field also it is not more than 130 degree. Nowadays this confrontation method is out of date. Very rarely we use it. Mainly we use it while the person has got difficulty in near vision. So we go for the finger counting or identifying the moving objects. Perimetry is totally gone. Now most commonly which is being utilized is computerized method to identify the field of vision and what are the defects. But before we measure the field of vision and look for the field of vision, you must look for movement of extraocular muscle. And also I already mentioned in a previous lecture of optic nerve examination, that is you must examine eyelids, conjunctiva, sclera, cornea, then anterior chamber, posterior chamber, etc. and position of eyeball. All these can affect your acuity of vision as well as field of vision. This is confrontation method. You are asking for eyeball movement. These are movement in 6 different positions. This is convergence and accommodation. This can also affect your field of vision as well as acuity of vision. And when you do by a confrontation method, perimetry method is gone. Confrontation method is you are sitting in front of the patient. Patient is closing his say right eye. We have to close our left eye and we are comparing our right eye view field with his left eye. So that is how you compare. This will be explaining you when you are attending a lecture. So this is the method in which you do it in all the 4 quadrants as well as obliques. Lateral, medial, upward, downwards, as well as in obliques. So patient is sitting face to face. He is supposed to close one eye. Suppose here he is closing his left eye. We are supposed to close our right eye and then examine in whether the person can identify the moving object. And we compare with our eye field. So this is one of the rough method we call confrontation method, which will help you to identify roughly is there any defect in the field of vision. So this is field of vision what you are examining by confrontation method. These are all those different methods by which you are examining. Now this field of vision can be affected by anything which affects the retina, or if there is any damage to the nerve pathway, optic nerve pathway, that is to retina, optic nerve, or we call optic tract, optic chiasma, lateral geniculate body, optic radiation, and even to occipital cortex, or we call visual area. Any one of these pathway, if there is a damage, it will affect your field of vision. Also we have mentioned before, it will be affected by cornea, aqueous humor, if there is any defect in this cornea, shape of the cornea or corneal opacity, corneal ulcer, any pathophysiology of cornea or anything in the anterior chamber, say collection of blood hyphema or pus collections or foreign body, lens, dislocated lens, then ectopia lentis, any one of those also can affect your field of vision. So cornea, eye chamber can affect the field of vision as well as acuity. And in that we can get absolutely normal field, we call normal. We can have total absence of vision, we call as total blindness. Or there is half field gone. If it is of the right side field, we call right side homonymous hemianopia. If it is a left side field, it is called left side homonymous hemianopia. You can have both side temporal field gone, bitemporal hemianopia, and nasal field gone of both eye, binasal. If you got an area where there is a loss of vision in a field, one eye field, other than blind spot, we call that as scotomas. You can have a quadrant field loss. So it can be upper quadrant, lower quadrant, and in that we will have to add temporal, nasal, etc. So that will be the different words which are being utilized. Here you can see here total loss of field we'll call as a monoocular blindness. Half field gone. Here this is left side field gone. So we'll call it this as a left side homonymous hemianopia. If in only one eye, say here there is a total blindness, here there is one side half field gone, this will be called as a hemianopia. And if there is a quadrant field loss, quadrantic hemianopia, and here you can see this is upper quadrant field loss, so this is upper quadrantic left side homonymous hemianopia. So these are the terms. So when a light falls on retina, that impulse is converted into an electrical impulse, traveled by optic nerve. Some fiber, that is nasal fiber, only crosses to the opposite side while temporal fiber remains on the same side. So that impulse will travel to optic tract, lateral geniculate body, optic radiation, occipital cortex. So this will be the way the impulse will travel. We'll be dealing in detail. So we'll be talking today at present of optic nerve pathway and finding of lesions at different level. While pupillary reflex pathway method, different types of pupillary reflexes, different varieties of pupil and pupillary reflexes, abnormality in light reflexes, etc. will be discussed in part 3. So impulse will travel from retina to optic nerve, etc. You can see here this is the field. This will be temporal retina. It will give nasal field, and nasal retina will have a temporal field of vision. So if there is one object which is on the right side, so left side temporal fiber will be having stimulus and nasal fiber of right eye will be having stimulus. So this nasal fiber crosses to the opposite side and temporal fiber remains on the same side. So if there is some object on the extreme right side, so left eye temporal and right eye nasal will be giving a stimulus, and that will go to left side cerebral cortex. You can see now. This will be better seen in next. I'll skip these 2 slides. We'll show you that further how exactly it goes. So you will understand very nicely. And upper field will go into lower. So when you have got a binocular vision, this is one side. So when you have got binocular vision, you can see that this particular is overlapping. So nasal field will be overlapping, and this will be right side temporal field, which will be by nasal fiber, and nasal field will be by temporal fiber. So that will be the peculiarity. So usually we say that nasal field of opposite eye and temporal field of this side. This will be the nasal field of this eye and temporal field of right eye. This is temporal, right side visual field, which is done by nasal, and this is by temporal fiber of opposite eye, and that will be giving rise to what we call as nasal field. So this nasal field and this temporal field together will give rise to right side visual field, and this will be left side visual field. Little complex, but do understand this. So light travels in a straight line. So if light from this side, that is left side temporal region, that will be falling on right eye temporal fibers. Clear? And left eye nasal. So this is called left side field. So left side field will be because of nasal fiber of left eye and temporal fiber of right eye. So combined field, this will be a binocular field. So lateral field will be because of opposite side, what we call as a temporal. This is a temporal fiber. But this particular field of right eye, this is a temporal field of right eye. So field of vision, as far as field of vision, and this is retina. So this temporal field of right eye, right side temporal field, will be because of temporal fiber of left eye and nasal fiber of right eye. Very clear? Hence, this is what we say that you get a field of vision because of components of both eye, right eye as well as left eye. You will understand much better as we come further. And this upper field will be because of lower retinal fiber. Lower field will be because of upper retinal fiber. And if you look properly, this is macular field of vision. This is for macular field. This is in the optic now just behind the eyeball. But as you go further close to the chiasma, macular field is in the center. Nasal field is medially. This. And this is temporal. This is upper temporal. This is lower temporal fiber of retina. But this will be lower temporal fiber will be responsible for upper field, and upper retinal fiber will be responsible for lower field. Same way, this is upper nasal fiber, lower nasal fiber. They will be responsible for lower and upper field. So because light travels. So if you see here, this fish which is on the right side temporal side will be very nicely interpreted by left side cerebral cortex, occipital cortex, while this apple will be seen much better by right side because light will travel in the straight line. So that is what, and it will be reverse. You can see the tail is laterally and mouth is medially, and that is how it is being interpreted. Now this will be showing you here.
Starting with a lens to focus light. The cornea
You can see this is a lens.
and is primarily
Light travels in a straight line.
the image on the retina.
You can see that image is inverted.
Of the eye.
Image is
The
inverted.
visual image focused on the retina is inverted top to bottom and reversed right to left. The part of the world that you can see without moving your head or eyes is called.
Now this is a binocular vision.
Each eye sees only a portion of this visual field. The visual field can be divided into right and
This will be
left
combination of the two.
hemifields. The right
Overlapping.
visual hemifield is seen by the temporal left retina.
This will be
and
temporal
nasal
field of
retina,
vision. This is
while the
nasal
left
field of
visual
vision.
hemifield is seen by the nasal left retina and the temporal right retina. The visual field can also be divided vertically into superior and inferior divisions.
Yes, this will be
Note that
upper
the
field. This will be
visual
lower
fields
field.
of both eyes overlap extensively in the central portion of each visual hemifield. This region defines the binocular field of view. Vision in the periphery of the field of view is strictly monocular, mediated by the most medial portion of the nasal retina. The center of the visual field projects its image onto the foveal region of the retina. On the retina, the
This
highly
center part is
specialized
by
fovea
fovea.
has a dense
So that gives you
concentration of
most
small
acuity
diameter
of vision.
cones and a one-to-one relationship between the cones and the bipolar and ganglion cells. Visual acuity is therefore especially high in this region. Now let's examine the pathways from the retina into the brain.
Now you
This
can see how
diagram
exactly
shows
the
a view
fiber
of
are
the
going.
base of the brain as seen from below. Note that in this view, the position of the two eyes is reversed. The axons of retinal ganglion cells exit the retina via the optic nerve. The optic nerve exits the eye in a region called the optic disc. Because there are no receptors in this region,
Here there are no
nothing
rods
can
and
be
cones,
seen in the
so
corresponding
it does
part of
not
the visual
interpret any
field.
light
This blind
response.
spot
So
does not
that's why it
appear
is
as
called as a
dark
blind spot
Rather, it is
at
simply a
optic disc.
region from which we cannot obtain visual information. The optic nerves cross at the optic chiasm, which is
This is
located
temporal
just
retina,
anterior
this
to
is
the
nasal
scalp of the
retina.
pituitary gland. In humans, axons from the
This
nasal
is optic
retina cross
chiasma, you
over
can
to
see
the
the fiber.
opposite side of the brain.
Nasal fiber are crossing.
Axons from the temporal retina project to the
So right
green
side
side of
fiber
the
will
brain.
cross to the opposite side,
After they
while
pass
temporal
the
fiber
optic
will remain on the
chiasm,
same side.
the axons of the retinal ganglion cells are known collectively as the optic tract.
So
Note that
optic tract of
information
one
from the
side will
left
contain
visual
temporal
field is
fiber of
carried
same
in the
side and
right
nasal
optic
fiber of
tract,
opposite side.
and information from the right visual field is
So you
carried
can
in
see
the
that
left optic tract.
left side visual field,
The vast majority of axons of the optic tract terminate in the lateral geniculate nucleus, or LGN, which is the
so it will
visual
end
part of
in
the thalamus.
this
However,
lateral
the
geniculate
axons of
nucleus, and
retinal
from there you
ganglion
will get a
cells
fiber we
also
call as the
project
optic
to
tract,
several other brain regions.
optic radiation.
Some axons of retinal ganglion cells extend to the superior colliculi, a paired structure on the roof of the midbrain. The superior colliculi help coordinate rapid movements of the eyes toward a target. Small bundles of optic tract axons also project to the suprachiasmatic nucleus in the hypothalamus. Cells in the suprachiasmatic nucleus are involved in the control of daily or circadian behavioral rhythms related to the light-dark cycle. Finally, optic tract axons from still other ganglion cells project to a collection of neurons that lies between the thalamus and the midbrain in a region known as the pretectum. This region is important as the
This is
coordinating center for
pretectal
the
nucleus,
pupillary light reflex, that is, the
where some of the
reduction in
fiber
the
will
diameter
make
of
a
the pupil
synapse
that occurs
and it
when
will take
sufficient
part in
light
pupillary
falls on the
reflex.
retina. The lateral geniculate nucleus serves as the primary relay nucleus for visual processing by the cerebral cortex. The right lateral geniculate receives information from the left visual field, the nasal left retina, and temporal right retina, while the left lateral geniculate receives information from the right visual field, the nasal right retina, and the temporal left retina. The spatial relationships among the ganglion cells in the retina are maintained in their targets as orderly representations or maps of visual space. The primate lateral geniculate nucleus has 6 layers, and input from the two eyes
This
are
is the
maintained in
representation.
separate layers within the LGN. From the lateral geniculate nucleus, visual information is
These are the
relayed to the
optic
visual
radiation,
cortex. Most of the axons
which
from
will pass through
LGN
internal
neurons
capsule and
the
then
optic
finally relay in the
radiation,
visual
which
cortex.
terminate in the visual areas in the occipital cortex at the back of the brain. In this lateral view of the brain, we see that axons carrying information about the superior
You
portion
can see
of the
this is a
visual
lateral
field
geniculate. From
sweep
there you
around the
get an
lateral
optic
part of
radiation.
the ventricle in the
So
temporal
these
lobe,
outermost
a place
fibers are called
called the
Mayer loop,
Meyer's loop, before
and
reaching the
this
occipital lobe.
superior,
Axons carrying information about
which
the
will be
inferior
for
portion of
inferior
the
visual
visual
field,
field
and
travel to the
inferior fiber will
occipital
be for
lobe.
superior visual
The
fields.
topographic order of visual information is maintained in the visual cortex. The fovea is represented in the posterior part of the visual cortex, whereas more peripheral regions of the
So
retina
center
are
part, that is
represented in
fovea, will be
progressively more
represented
anterior
here.
regions. Note that the area of central vision, the fovea, is represented over an especially large part of the visual cortex. Inputs from the two eyes converge at the cortical level, making binocular effects possible. The primary visual cortex, V1 or striate cortex,
And that is
projects to
responsible
other
for
areas
binocular
of the
vision.
cerebral cortex, referred to as extrastriate, that are involved in complex visual perception. The dorsal stream, which includes the middle temporal area, leads from striate cortex into the parietal lobe. This system is thought to be responsible for spatial aspects of vision, such as the analysis
This
of
is in
motion
little bit in
and
detail.
positional relationships between objects in the visual scene. Another system, the ventral stream, leads from the striate cortex into the inferior part of the temporal lobe. This system is thought to be responsible for high-resolution form vision and object recognition.
Now we'll be explaining the same thing. You can see here now. This is left eye. Temporal fiber will be responsible for nasal field. This will be nasal fiber which will be responsible for temporal field of left eye. Same way, this will be right eye. This is temporal fiber, nasal field. Temporal field of vision, this will be nasal retinal fiber. And now you will see that how exactly it goes. See, this temporal fiber runs on the same side. This is temporal fiber, nasal field. So they run laterally in optic nerve, optic chiasma, optic tract, and ends in lateral geniculate body of left side. You can see this particular temporal fiber, but nasal field of right eye runs on lateral side, that is temporal fiber, optic nerve, optic chiasma, optic tract, and lateral geniculate body. While nasal fiber of opposite eye, that is left side, that is nasal fiber of retina, medially crosses in the center part of chiasma to the opposite side. Means left side fiber will cross to the right side and right side fiber will cross to the left side, and then it will end in lateral geniculate body of opposite eye. You can see here also this crosses to the opposite side and opposite eye. So now this lateral geniculate body is getting a fiber, temporal retinal fiber of same side and nasal retinal fiber of opposite side. Indirectly, this is what we call as left side field, and this will be receiving right side field. So that is the presentation. So optic nerve, optic chiasma, optic tract, lateral geniculate body, and then optic radiation. And via optic radiation, the fiber will end into occipital cortex. We'll be showing you that in detail further. So now this particular, depending upon where you get a damage, you will be understanding very easily. Now pay attention, it will be very, very simple. Now suppose if I get the damage at 1, this is right eye, and at 1. So my temporal fiber of right eye is damaged, nasal fiber of right eye is damaged. So my right eye will not receive any input. So in right eye, I will have no vision. So I will have total loss of vision in right eye. We'll call right side blindness. Right side blindness. No input. Clear? So my nasal field of right eye, temporal field of right eye is gone. This will be as far as monocular vision is concerned. Totally gone. Now if I get the damage at this 2. So this is containing nasal fiber of both eye. So nasal fiber of this eye is giving temporal field of same eye, and here it is temporal field of opposite eye. So both side temporal field gone. So we call that as a temporal hemianopia. As it is half, we also use the word bitemporal homonymous hemianopia. So whenever you get a lesion at optic chiasma, both nasal fiber is gone. You will have a both side temporal field gone. So we use the word bitemporal homonymous hemianopia. Suppose you have got a damage at 2B here, 2B. So if you get a damage at 2B, means your temporal fiber are damaged because temporal fiber are laterally. So right eye temporal fiber are damaged. So I will have a right side nasal field gone. So we'll say that right side nasal field loss. But if I get a damage on both sides and both side temporal fiber are gone, I will have both side nasal field gone. So it will be binasal hemianopia. Absolutely rare, but in a case of cavernous sinus thrombosis, you can have this center part of optic chiasma, pituitary fossa or hypothalamic craniopharyngiomas or pituitary tumors will produce damage to optic chiasma. Simple example, craniopharyngioma or pituitary tumors. This is absolutely rare, very rare in case of what usually we come across in case of what we call as cavernous sinus thrombosis group. Now, if you get 2 plus 2a, 2 plus 2a, 2a means temporal fiber of opposite eye is gone, that is left eye. So temporal fiber gone, so nasal field gone. Plus here if you say 2 plus 2a means this is producing nasal fiber damage. So both side temporal field gone and nasal field of left eye is gone because temporal fiber is gone. So that will produce typical 2 plus 2a. This is 2a plus 2b. So that if you get 2a plus 2b, you will have a binasal. Because of 2a, you will be having also, this is 2a plus 2. So it is this field gone. So nasal and this is gone. Now here if you see 3 means right side temporal fiber and left eye nasal fiber. So it is a left side field gone. So nasal field of right eye and temporal field of left eye. So we'll use the word left side homonymous hemianopia. And if you come across the outer fiber which is starting from lateral geniculate body, that is 4 at 4, this particular fiber, outer fibers, and when outer fibers are damaged, it is if you look properly, it will be left upper quadrantic field gone, upper quadrantic, because these are lower fibers. Fibers are lower retina fiber, field wise upper, while inner fibers are superior fibers. They will be responsible for inferior field of vision. And when you get the damage at the level of 7, this is 6 will be complete. 6 will be complete means both upper quadrant as well as lower quadrant gone. But as you come closer to occipital cortex, there will be macular sparing. And when you get the damage at 7, it will be only left side homonymous scotomas. That will be very peculiar of 7 when you get damage here at 7 level. So this will be the different. Now we'll be going through all those different way. This inferior fibers are called Mayer loop. Then there is a loop called as a Bohm's loop. You will be looking here. This will be normal field, total loss we call anopia, central damage, both side nasal fiber damage, so it will be responsible for temporal field. So bitemporal hemianopia. If you get the damage to the temporal fiber, it will be nasal anopia and binasal hemianopia. If you get the damage here in optic tract, homonymous hemianopia. If you get the damage on the right side, you will have a left side homonymous hemianopia. And when you get the damage in medial fiber or lateral fiber superior field, medial fiber inferior field. And when you get the damage at level 5, you will have a macular sparing, and if you get the damage at 6, it will be macular degeneration, which can produce central loss of field. Central field will be lost in macular degeneration and diabetic retinopathy. That will be very, very peculiar. The centermost part is called fovea, and surrounding that area is called macular field. You can see here, these lateral fibers are called Meyer lobe, and this fiber are called Bum's lobe. And this Meyer lobe is responsible for inferior retinal fiber, means superior field, and this Meyer lobe is responsible for inferior field, means they are superior fibers. So these are inferior fiber, these are superior fiber. We have already shown you that. And part of the occipital cortex is responsible for macular field of vision, and so you can have a macular sparing. So this is superior fibers, these are inferior fiber Meyer lobe, this is Baum's lobe, and this will be responsible for inferior field, this will be responsible for superior field, and here this combined together will call that as optic radiation. So these are the part of optic radiation. This is lateral geniculate body, this is optic chiasma, and again in optic chiasma, if you see, these are the superior fibers, these are inferior fibers, and I have shown you one diagram before also. So at occipital cortex, you can get a quadrantic field of loss with macular sparing as you go closer to occipital cortex. Here you can see right side total loss. So right side monocular blindness, right optic nerve damage. Here you can see both sides. This side temporal field gone and this side nasal field gone. So it is a right side field, sorry, this is white is a damage. Here also white is a damage. So here you can see that this side temporal gone, this side nasal gone. So this is left side field. So as it is a left side field, left side homonymous hemianopia. And this will happen when you get the damage to right side optic tract. Right side optic tract or at lateral geniculate body or complete optic radiation. And when you get a quadrantic loss, here you can see this is a quadrantic loss. So this is right side field loss, upper quadrant means left side damage, and again in left side this is upper field gone, so inferior fibers are damaged, and inferior fibers are Baum's loop. No, Baum's loop is superior and inferior fibers are Meyer's loop. So inferior fibers are damaged, so Meyer loop is damaged. So right side superior quadrantic hemianopia, and it will be a left side Meyer's loop. So left side superior, this is showing you left side superior gone. Left side superior gone. So it will be concerned with right side superior gone. So right side Meyer loop. Right side Meyer loop. This will be bitemporal. So bitemporal means both nasal fiber gone. So optic chiasma, bitemporal hemianopia. So central part of optic chiasma. This left eye completely gone and right eye temporal gone. So right side nasal hemianopia, right eye nasal hemianopia. So right side, lateral side of optic chiasma is damaged because this is gone. Black is gone. This is lower quadrantic gone. Bitemporal inferior quadrantic hemianopia. So when you get inferior, superior fibers are gone, so bumps look. Upper part of optic chiasma. This is macular sparing. Typical macular sparing. This is bilateral upper quadrantic gone. Bilateral temporal upper quadrantic loss. Meaning bitemporal superior quadratic hemianopia. Superior means inferior fiber. Again, Mayer loop gone. Lower part of optic chiasma. Bitemporal at optic chiasma. This will be both side. This is here. This is lower quadratic gone. So superior fiber affected. And it is right side. Right side means left optic radiation damage. And left optic radiation damage, this is left side inferior, so right side damage. So this is right inferior quadrantic hemianopia. So Bohm's loop, here this will be left side. So left side Bohm's loop. And when you get, this is a blind spot. Other than blind spot, this will be all scotomas. And that will be very common either because of corneal opacity or because of some foreign materials, floating objects, blood clots, exudates in anterior chamber or posterior chamber or something in a lens or in retina. So these are called scotomas. This is blind spot. Macular degeneration can produce. Now you have to identify what is A. Take time. What is B? Bitemporal. What is C? It is right side nasal field gone. So damage at the level of optic chiasma laterally. Right side nasal hemianopia. Then both left side homonymous. At D. If you get at E, it is outer fiber. Outer fiber are for superior field. Inner fiber are for inferior field. So outer fiber, left side superior, left side inferior. Outer fiber, we call that as Mayer's loop. Inner fiber, Bum's loop. Same thing. At your leisure time, you can write down what is 1, what is 2, what is 3, what is 4, what is 5, what is 6, what is 7. Just make an attempt. These are all quiz. You can have a pause and these are the answers. So at your leisure time, you can go through. Again, same thing here. What is 1? What is this? 1, 2, 3, 4, 5, 6 and 7. And these are the answer. Make an attempt. Have a pause first, answer, and then you can see how much you have gathered your knowledge. These are again the questions and answers. So this is a question, what field loss? This is one side, monocular blindness. So right side. So there has to be something with right optic nerve. So right side optic nerve gone. So have a pause, try to answer. Have a pause, answer. Here say both side. This field gone, this field gone. So bitemporal. So lesion has to be at center part of optic chiasma. So try to answer that. So this is C, this is D, this is outer fibers at G1 and G2, G1 and G2. So this will be G1, G2. So you have got little sparing. So macular sparing. This will be at G1 level. This is at F, that is inner fiber, lower quadrant, outer fiber, superior quadrant. This is superior quadrant, this will be Meyer loop. So try to go through that. This is cortical blindness, we are not much interested. Bilateral occipital lobe lesions in the lingula or fusiform gyri will rarely no field defects. Unilateral involvement may cause hemidyschromatopsia. We are not much interested. This is called cortical blindness due to bilateral occipital lobe lesion, often misdiagnosed as a functional visual loss. It is very common in stroke, eclampsia, hypertension, carbon monoxide poisoning, etc. We call cortical blindness. This is dyschromatopsia, bilateral occipital lobe lesion in lingule or fusiform gyri, where there is no field defects. And unilateral involvement will cause this particular hemidyschromatopsia. There is something called as Alexia without Agraphia, loss of ability to read but can write. That is, reading is Alexia. Without Agraphia means person can write. If you say Agraphia means person is also not able to write. And that will happen very commonly if there is a left occipital lobe damage. This is palinopsia, persistence or recurrence of visual stimulus after it has been removed. That is palinopsia. This is again a quiz if you want to go through at your leisure time. Start from 1. What are the different lesions and where is the lesion? So I end my lecture here. I hope this will be helpful to you. If you like this particular lecture, don't forget to press button like, subscribe, and you can share with your friends. Thank you very much for taking out time. I know that your time is valuable and appreciate that you have spent some of the time with me. See you in next lecture. In next lecture, we'll be dealing with pupil, pupillary reflex, light reflex, and all disorders concerned with pupil and light reflexes.